I am Dr. DJ Christopher. I head the Department of Pulmonary Medicine at Christian Medical College, Vellore. Over the next 15 or so minutes, I want to discuss with you pathophysiology and clinical features of COPD. COPD was thought to be a rare disorder, but today all of us know that that's not the case. It is not just a more frequently encountered disorder, but it's also important in that there's substantial morbidity and mortality associated with COPD. So what happens in COPD when people inhale smoke and particulate matter into the lungs? The most classical mode in which patients do this is by smoking tobacco through cigarettes. This is a well-known risk factor. In our country, several relatively poorer people use BDs. BDs are indigenous tobacco smoking devices. These emerge from cottage industries, and so there is a lot of variability in the amount of tobacco that is present in each BD. What was not initially known but is well known is that biomass fuel, that is an important factor in the onset of COPD in many rural women. The picture here shows you a rural woman who is engaged in cooking, and it is possible to appreciate that she is cooking in a poorly ventilated room or kitchen, and alongside is a small girl. So this picture depicts first that several hours of exposure to smoke within this confined space is an important factor in the life of these women. Equally important is the fact that this exposure starts very early in life, especially for girl children. Occupational factors are important. Occupations where there is exposure to tobacco, to smoke of any form, and particulate matter are important risk factors for COPD. What actually happens to the lungs when a patient inhales smoke or other toxic fumes? Let us look at the classical cigarette smoking model. To start with, it affects the epithelial cells and the alveolar macrophages, which are the ones that these irritants first come in contact with. And then once they permeate deeper, they encounter lymphocytes, neutrophils, and monocytes. All these cells produce chemicals which work on fibroblasts and result in more fibrosis. They also produce chemicals that cause inflammation and destruction. In particular, there are several proteases which cause destruction of the alveoli, resulting in what is called emphysema. These chemicals are also responsible for mucus hypersecretion. I want to show you the comparison between the appearance of a healthy lung and the lung of a COPD patient. They are side by side for you, and just the appearance is strikingly different. First, the healthy lung is towards a pinkish color and looks healthy, whereas the COPD affected lung is gray and even towards black color due to the inhaled particles that have resulted in coloring the lung this way. The second thing that you see is the heart. The heart of the person with healthy lung is of normal size, whereas the heart of the person with COPD in this picture is enlarged. This is the effect of severe lung disease resulting in hypoxia that causes strain to the right side of the heart and therefore hypertrophy of the right-sided chambers in particular. Thirdly, we see that the lung is substantially larger in COPD patients. This is the consequence of what we call hyperinflation, which I will describe in a while. There are two components in the pathophysiology of chronic bronchitis and emphysema, which together make up what is called COPD. The first, let us start by describing the features of chronic bronchitis. The airways, particularly the larger airways, have mucus hypersecretion, inflammation, and the smaller airways, in addition, have peribronchial fibrosis. And these factors lead to airways obstruction. So chronic bronchitis is characterized, therefore, by airways obstruction as well as increased mucus production. The second factor is emphysema. Emphysema is characterized by destruction of the alveolar ducts and the alveoli. These are crucial parts of the lung that deal with air exchange. I want to show you a microscopic picture of the normal lung, and I am going to compare that with a COPD lung. On the left side of the screen is a normal lung, and on the right side a COPD lung. Compared to the normal lung, there is bronchial wall inflammation, there is mucus gland hypertrophy. The ones you see below, the rounded structures are mucus gland. The epithelium itself is denuded and there are metaplastic changes. There is a thick layer of mucus and the smooth muscle layer is substantially thicker, what is called smooth muscle hypertrophy. These patients would therefore present with cough and sputum production. The mucus hypersecretion which we see in the picture will result in cough and an effort to expectorate. There will also be breathlessness because of the airways obstruction. On the other end of the spectrum, there are patients with changes called emphysematous changes. These are alveolar destruction. As I described a little while ago, these structures are pivotal for airway exchange. And because of destruction of these structures, there is compromise of gas exchange. And as a consequence of this also, patients would be breathless. I want to explain to you a feature of emphysema that is responsible for severe distress and excessive breathlessness that COPD patients face. Patients with emphysema experience something called air trap. This causes significant distress as well as dyspnea. I will explain the mechanism involved with it. What you see in the diagram, the slide, is the airway of a normal person. You can see alveolar attachments which are healthy and taut. During exhalation, the airway caliber narrows in normal people, but the attachments are firm and therefore the reduction in caliber is not substantial. On the other hand, in those with mild or moderate COPD, there is loss of elasticity, and when they exhale, the airway caliber narrows significantly, presumably resulting in symptoms. In those with severe COPD, there is even destruction of these attachments, and so when they exhale, there is even complete closure prematurely before exhalation is complete. And this leaves the patient with severe chest discomfort, a sense of not having exhaled completely, and dyspnea. This phenomenon is called air trap. What are the symptoms of COPD? The classical symptoms are breathlessness. Breathlessness is progressive and it increases with exertion. It may also be wheezy. Now, wheezy breathlessness, although is more common in asthma, can also be encountered in COPD. There is a saying, all that wheezes is not asthma. And one of the conditions that wheezes but is not asthma is COPD. Chronic cough is the other symptom with sputum production. Since both COPD and asthma present with breathing difficulty and both patients may have wheeze, I want to spend some time discussing the difference between the two conditions. Age of onset for COPD is usually later in life, when the inhalants that cause damage to the lung have had time to work in the lung and cause the damage. So that usually occurs in the 4th to 5th decades of life. In asthma, however, the onset of symptoms is in childhood or early adulthood. The course of COPD is progressive. COPD patients continue to worsen month after month and year after year. Asthma patients, on the other hand, may revert to normalcy or with treatment and may remain normal for a long time. Smoking and other exposure factors are common in COPD but rare in asthma. Nasal symptoms as well as other allergic or atopic disorders are rare with COPD and common with asthma. So in asthma, you would look out for features like allergic rhinitis, allergic dermatitis, conjunctivitis, and so on. Triggers are usually not known to worsen symptoms. On the other hand, with asthma, these are frequently identified. Wheeze may or may not be present in COPD but is prominent and a common feature with asthma. Lung hyperinflation on chest X-ray is commonly encountered in COPD but rarely ever encountered in asthma, and even if it is during acute attacks. Long-term complications are a feature of COPD, and patients could present with respiratory failure or cor pulmonale when the disease is advanced. There are no such situations described for asthma. COPD is also characterized by exacerbation. So exacerbation is defined as patients' respiratory symptoms that is beyond normal day-to-day variations and leads to a change in medication. There are three cardinal features of COPD exacerbation: increase in dyspnea, increase in sputum volume, and or sputum purulence. It is important to understand that the disease is not confined to the lung. It is in many ways a multi-system disorder. Therefore, the comorbidities that could be encountered with COPD are fatigue, sleep apnea, heart disease, ischemic heart disease, arrhythmias, heart failure. In fact, the most common cause of mortality in COPD patients is from cardiac causes. Acute kidney injury, osteoporosis, muscle wasting, diabetes, stroke, anxiety, depression. So several disorders can coexist with COPD, or COPD has several non-pulmonary disorders that also occur. Thank you very much for your patience.